Today we are going to discuss what is intrinsic PEEP. Intrinsic PEEP is also known as auto PEEP. As you know, it is not very uncommon, but many times we fail to recognize it, and that leads to problems in the ventilation of the patients. So let's start. So first of all, you need to know what is PEEP. So PEEP is positive end expiratory pressure, which is the pressure inside the alveoli at the end of the expiration. That's PEEP. And what is intrinsic PEEP or auto PEEP? Intrinsic PEEP is the PEEP that is present inadvertently. That means you have not applied that particular amount of pressure, but it is there at the end of expiration inside the alveoli. So that's your intrinsic PEEP. Now, why are we discussing this? Why are we so worried about intrinsic PEEP? So we need to know what are the consequences or the side effects of intrinsic PEEP. So first of all, intrinsic PEEP will increase the work of breathing. We will discuss that later in the in this video, what exactly it does to the work of breathing. But for now, you need to remember that it increases the work of breathing. The other thing is, a lot of studies have shown that the intrinsic PEEP can worsen the gas exchange of the patient. Oxygenation may be poor. Another important effect is the hemodynamic effect. So since there is some pressure inside the alveoli, it makes venous return more difficult. And if the patient is already hypovolemic or the intrinsic PEEP is progressively worsening, then your patient might have hypotension, or eventually at some point the patient may have PEA, cardiac arrest. And it is a very common question in the OSCE and practical exams that for example, a COPD patient has come with exacerbation, you have intubated this patient, and now suddenly the patient has a PEA arrest. What do you do? And rather than starting the CPR, you will think that probably this all could be because of intrinsic PEEP, and you would just disconnect the ventilator to the circuit and let the trapped air come out. So that's one of the common questions, and I thought you would be interested to know. The fourth side effect or consequences of intrinsic PEEP is it confounds your values of CVP or PCWP, or so based on that your decisions in the treatment may get affected. Fluid resuscitation may be affected, so it interferes with your daily decisions in the ICU. So that's the importance of knowing about intrinsic PEEP and knowing about what are the problems of intrinsic PEEP. Okay, so now we will discuss what are the types of intrinsic PEEP. So we need to first understand, in most of the cases when there is intrinsic PEEP, there is dynamic hyperinflation. This dynamic hyperinflation is because of air trapping. Okay, so now we can subdivide further into two categories: whether there is dynamic hyperinflation with expiratory airflow limitation, or whether there is dynamic hyperinflation without expiratory airflow limitation. Now in the first category, the examples would be COPD and asthma. So we will take them one by one. So what happens in COPD is that the alveoli, which normally exert a radial traction on your distal bronchioles, are destroyed, which leads to loss of traction on the distal bronchioles. This especially becomes more important during expiration. So during expiration, since there is loss of traction, loss of radial traction on the distal bronchioles, they are collapsed more easily, and this leads to blockage of the distal bronchioles and trapping of the air. Similarly, in asthma, there is excessive tone of the smooth muscle and hypertrophy of the smooth muscle in the distal bronchioles, and this leads to prolonged time for emptying, and sometimes the patient has to take a next breath, and this leads to air trapping. Whenever there is exacerbation of COPD or asthma, there is more mucus plugging, there is more bronchoconstriction, which adds to the ongoing problem. And in exacerbation, these patients may manifest with intrinsic PEEP and the side effects because of that. So that's about the dynamic hyperinflation with airflow limitation during expiration. The second type is dynamic hyperinflation without airflow limitation during expiration, and here your ventilatory strategy becomes very important. So if you apply certain breathing pattern like high tidal volume more than 10 or 12 mils per kg, or rapid respiratory rate more than 30 or 35 per minute, both leading to increased minute ventilation. This will lead to excessive air entering the lungs but not able to come out because of the time constant of the alveoli. Also, when we ventilate ARDS patients, sometimes we, for the sake of improving oxygenation, we change the inspiration to expiration ratio, we prolong the inspiration, or sometimes we apply inspiratory pause. These all lead to prolonged inspiration and improvement in oxygenation to some extent, but this also shortens the expiration, and that leads to dynamic hyperinflation and air trapping, which eventually would lead into intrinsic PEEP. Also, sometimes there is a small bore endotracheal tube, or there is obstruction or some resistance in the ventilator circuit or valve, expiratory valves. This leads to difficulty in emptying or expiration of the during the ventilation, and this can also lead to air trapping and dynamic hyperinflation. Can we say that dynamic hyperinflation and intrinsic PEEP, they are both the same? Actually, no. So they are both the same to a large extent, but there is a small set of patients where there is no dynamic hyperinflation, but patients' excessive expiratory muscle recruitment might also lead to formation of intrinsic PEEP. So that's a very rare or very less common entity, but because of that, we cannot say that all the patients having intrinsic PEEP would have dynamic hyperinflation. So some of them would not have dynamic hyperinflation and they would still have intrinsic PEEP. That is the patients with recruitment of expiratory muscles. So we need to remember that. Now, how do we identify the intrinsic PEEP? So when you are ventilating a patient and you look at the ventilator screen, you can see that the flow versus time scalar, the exhalation would not come to the baseline or zero, and the next breath or next inspiration will start before that. That means that there is some intrinsic PEEP. However, you cannot measure any intrinsic PEEP by looking at the scalar, because it is a scalar of time versus flow. It is not a scalar of pressure. So intrinsic PEEP is a measure in pressure, and the scalar that we discussed is flow. So, but looking at the typical waveform, you can tell that okay, this patient is having intrinsic PEEP. Another way to identify is if you can see that the patient is making inspiratory effort, but that is not converted immediately into a negative deflection and beginning of a new breath in the pressure versus time scalar. So that patient trigger, patient effort, and the ventilator negative deflection takes a little, there is a little pause in that. That is a sign that there is some delay, probably because of excessive work of breathing, and that is probably secondary to intrinsic PEEP. Another way to know is if you apply extrinsic PEEP on the ventilator, your peak airway pressure would not go up. That would mean that whatever extrinsic PEEP you are applying is rather less than intrinsic PEEP. This would apply in COPD asthma patient, and that's why because of that intrinsic PEEP, the peak airway pressure is not going up. Another way, the final way, is in paralyzed or sedated patients. When you detach the patients from the ventilator and reapply after a few seconds, there is reduction in the plateau pressure, which means the trapped air has come out and the dynamic hyperinflation has been relieved for that time being. So these are the ways to identify whether the patient has intrinsic PEEP or not. Now, if you really want to measure intrinsic PEEP, there are two ways to do it, static or dynamic. So if you want to measure static, most of the ventilators have expiratory hold. So when you apply expiratory hold, the expiration is finished and then there is no flow. And at that time, you would notice certain pressure, which is your intrinsic PEEP. Generally, it could be less than 4, and then it is not much of significance. But if it is more than 4, that is definitely of significance. So some of the ventilators would directly give you intrinsic PEEP. Some of the ventilator would show you total PEEP, and you have to subtract the extrinsic PEEP or applied PEEP. So for example, if the after expiration hold, if the ventilator shows 15, that is total PEEP, and you have applied a PEEP of 5, then that means the intrinsic PEEP is 15 minus 5, that is 10. So that's how you measure the intrinsic PEEP, by giving expiratory hold. Another way or dynamic way is to put a esophageal manometry and monitor the intrinsic PEEP, which is more difficult and not very commonly used. Now, so this is, I think we have discussed about the intrinsic PEEP. Now, what is the treatment? So you need to find out why the intrinsic PEEP is happening, and you need to troubleshoot by treating the underlying cause. What all measures you can take? So you can change the ventilatory settings if that is the issue. You can reduce the patient ventilatory demand and minute ventilation, and you can minimize the airflow resistance. Now we will discuss further. So what settings you can change? So you could reduce the tidal volume or ventilatory rate to a more physiological rate. If the patient is anxious, the oxygen demand or ventilatory demand is very high because of anxiety, pain, fever. You could try and control these symptoms. You could reduce the dead space to ventilate more effectively. You could have to give sedatives or paralysis to these patients to facilitate the ventilation. But these are the measures which could help you overcome the intrinsic PEEP. Now, if there is flow resistance or expiratory flow resistance, then you have to consider using a large bore endotracheal tube. If there are secretions, you may have to suction frequently, you may have to give bronchodilators, and you may have to counterbalance the expiratory flow limitation by applying extrinsic PEEP. So now we will discuss that in more details. In this section, we will also discuss why there is increased work of breathing when we have intrinsic PEEP. So first question that arises is external PEEP helpful for all the patients who have intrinsic PEEP? The answer you might have understood so far. The answer is no. Extrinsic PEEP is helpful in only a selected set of patients, those who have expiratory airflow limitation. These patients are COPD exacerbation and asthma exacerbation. The other patients like sepsis, your ARDS, or other causes, respiratory muscle weakness, for example, these patients are not going to benefit by application of external PEEP because the problem is different. The mechanism of intrinsic PEEP is different. There is no expiratory airflow limitation. So you have to remember that. Now let's look at this diagram. So you can see this is the end of expiration in a normal patient who is breathing spontaneously. So at the end of expiration, the atmospheric pressure is 0, the alveolar pressure is 0, and the pleural pressure is -5, for example. Since the alveolar and atmospheric pressure are same, there is no flow of air in any direction. Now what happens during the inspiration? The diaphragm actively contracts, which leads to more negative pleural pressure. So now the pleural pressure, for example, is -8. This leads to more negative pressure generation in the alveoli. So now in our example, it is -1, and the atmospheric pressure is not going to change. So there is a gradient created between the alveoli and the atmosphere, and the air will flow from atmosphere into the alveoli. This is during inspiration. So this is what happens during the normal breathing. Now we will discuss what happens when there is airflow limitation during expiration. So if you look at this figure now, the atmospheric pressure is still 0, but because of the COPD or asthma, the airway obstruction is now there, and that leads to accumulation of air in the alveoli, and the alveolar pressure now is +10 centimeter of water. This positive pressure in the alveoli is also transmitted to the pleura, and the pleural pressure is also 10 centimeter of water. So this is what happens when there is trapped air in the alveoli because of COPD or asthma. Now, for example, if this patient wants to take a breath, the diaphragm would contract. But to create a negative gradient, the diaphragm would need to contract more than 10 centimeter of water to generate a negative pressure inside the alveoli. So for in this example now, the diaphragm has contracted so strongly that the pleural pressure has become -13 centimeter of H2O, and the alveolar pressure is now -3 because it was already +10, and now the pleural pressure is -30, so the difference is -3, and this -3 centimeter of water pressure in the alveoli would lead to inspiration or flow of air from the atmosphere into the alveoli. So what we have seen here is, compared to the normal patient, the effort or the pressure that the diaphragm needs to generate to create an inspiratory breath is significantly higher. The diaphragm has to overcome the pressure which is already there inside, and with each breath the diaphragm would have to work more. This will increase the work of breathing. These patients are at the risk of tiring and having respiratory failure, predominantly type 2 respiratory failure. So this is something which is very important to recognize in time. Now, in the same patient, when you intubate them and apply external PEEP, this external PEEP will help open the collapsed alveoli. It will act as a stent and it will counteract the intrinsic PEEP. So now the diaphragm, whenever it contracts, even a lesser pressure change will be sent to the ventilator, and a next breath will be delivered. So it will improve the work of breathing if you apply external PEEP. So that's the basic funda why we apply external PEEP in this set of patients. So let's understand how we can apply, how much external PEEP we can apply for a COPD or asthma patient when we ventilate them. We will use the analogy of a waterfall. So as you can see, the auto PEEP is the upstream pressure and the applied PEEP is the downstream pressure. Now, until you apply the uh, extrinsic PEEP above the critical pressure, it is not going to affect the upstream pressure. So even if your external PEEP is 0 or your external PEEP is 5 or 7 or 10, not 10 but 5 or 7 or 8, this is not going to affect the upstream pressure, which is, for example, here it is 10. Now if you apply extrinsic PEEP same or higher, so for example if you apply a pressure of 10 or 12 externally, then it will increase the auto PEEP as well, because it has crossed the critical level, and whatever pressure you are applying will directly be converted, or it will add to the intrinsic PEEP, and it will not be helpful. So how do we know how much is the intrinsic PEEP? So as you know, different alveoli have different time constants. Some of the alveoli during your extrinsic pause may not really open, so it is very difficult to know how much is the intrinsic PEEP. But the general consensus is, whatever intrinsic PEEP you can measure by giving expiratory hold, the extrinsic PEEP that you apply should be around 80 to 85%. This will ensure that you are not crossing the critical level, and your extrinsic PEEP that you are applying is actually helping, not rather worsening the patient's intrinsic PEEP. So that's about the how much extrinsic PEEP to apply. I hope you have understood this topic. It is very important. You have to, in day-to-day circumstances, many times we miss this. Many times patients develop hypotension or other side effects of intrinsic PEEP, and many times we miss these situations because we don't know what has happened. So it's always good to know the basics, to understand, and to be ready with a remedy. If you like this video, please subscribe my channel. Please spread it to other friends and colleagues who might be interested. Till we meet in the next video. Bye.